Good afternoon. Welcome to the Wednesday afternoon lecture series. And for me, I'm Dan Xi, the program director at the NCI. And in my role here today, I represent the Asia American and the Native Hawaii and Pacific Islander Health Scientific interest group, who nominate today's speaker, Dr. Maria Rosario and Araneta. It is a great honor to introduce Dr. Araneta, who has provided a remarkable insight into the alarming prevalence of the type 2 diabetes among the Filipino and the South of Asia. But I have two for the announcement first. For those who are watching and remotely, we encourage you to participate in the Q&A. So you can do so by clicking on the button, which is just below the video cast window that says Send Live Feedback. And click on that, type in your name and question. And we will relay this to Dr. Araneta at the end of her talk. You can submit the question anytime, and I hope you do so. For those who are here in the auditorium today, you can use the mic to your left and to your right. Also, we are offering the continuing medical education, the credit for this presentation. The CME code for today is 50126. I will repeat that, 50126. So, our today's speaker, Dr. Araneta, is a professor in the Department of Family Medicine and Public Health, the Division of Epidemiology at the University of California and San Diego. She has numerous roles as UCSD. She is Association Dean of the Diversity and Community Partnerships at the UCSD School of Medicine. She is the co-principal investigator of the diabetes prevention program's outcome study, where UC San Diego is one of the 26 participating sites. She's also the PI of UCSD's Filipino health study, a longitudinal study of the diabetes and cardiovascular disease and the osteoporosis among the Filipino men and women. And she is the investigator of the ranching prenatal study, where she leads the research on the ethnic health disparity among the Caucasian, Filipino, and African American. More broadly, her research and interests also include the maternal and the pediatric HIV/AIDS, the birth defect, the life course exposure, the cardiovascular disease, and the metabolic abnormality. In her epidemiological research, Dr. Araneta has helped to identify the novel risk factor for the diabetes among the Asian American. These include the excess of visceral and the hepatic fat accumulation, selected cytokines, the lowered beta cell function, and the gestational diabetes. Dr. Araneta received her undergraduate degree in biology from UCSD and her MPH and PhD in the epidemiology from the Yale University. She has received several awards for her research. This includes Vivian, Fonseca, and Nagadron family diabetes, the research award from the American Diabetes Association, and the selection to the NIH Council of Councils. She also is the recipient of an NIH grant investigating any connections before the diabetes and the dementia. The title of Dr. Araneta talk today is the type 2 diabetes among the Asian American, elevated prevalence and novel risk factor. Now, please help me to welcome Dr. Happy Araneta.
Thank you. Good afternoon. Magandang hapon. Thank you for the generous introduction, and thank you for this esteemed invitation to be a WALS lecturer, especially during Asian American, Native Hawaiian, and Pacific Islander Month. So in recognizing the contributions of not just Asian American, Native Hawaiian, Pacific Islander researchers and health professionals, also wanted to acknowledge the participants in the 3 studies I'm going to feature today. Since 2016, Asian immigrants have already exceeded the number of Latino immigrants. The projected number of Asian immigrants is, the projected number of the Asian American population is projected to climb to 35 million in the next 15 years and 46 million by 2060. 24 million Asian Americans currently comprise 7% of the U.S. population. The largest are Chinese, Indian, Filipinos, and Vietnamese. And then recent immigrants coming from Burma, Nepal, Myanmar, and Cambodia comprise smaller groups, but it's also important to acknowledge that these groups represent over 100 languages, which made it quite challenging to provide translation services at the peak of the COVID pandemic. There are also broad disparities in socioeconomic backgrounds of the diverse Asian American populations, varying in college attainment as well as income. There have been limited cohorts, clinical cohorts of Asian Americans, and a lot of the prevalence data have come from electronic medical records. This paper, published by Andy Carter in 2013, shocked the medical community. It was based on 2 million members of Kaiser Northern California Permanente members, which is generally representative of California's population. And whenever I ask our medical students, name the 3 racial ethnic groups with the highest prevalence of type 2 diabetes, they usually respond with Latinos, African Americans, and Native Americans, when in fact in California, it's Pacific Islanders, and that's mostly Native Hawaiians, Samoans, and Guamanians. Second are Filipinos, and third are South Asians, coming from India, Pakistan, Bangladesh, and Nepal. But if you look at the other groups of Asian subgroups, Southeast Asians, people from Vietnam, Cambodia, Japanese, Vietnamese, Korean, and Chinese, they also have elevated diabetes prevalence compared to whites. In this graph, you'll see the orange line representing a BMI of 30, or the definition of clinical obesity. And you'll see that among whites, blacks, Latinos, Native Americans, and Pacific Islanders with incident diabetes, that appears in the gray graph, or those with prevalent diabetes that appears in the white bar, they're all exceeding a BMI of 30 kilograms per meter squared, but not so among Chinese, Japanese, and Filipinos and South Asians, who have BMIs less than 30. And then 6 years after this paper was published, Kaiser did the analysis again among adults over the age of 45 and found similar trends with Native Hawaiians and Pacific Islanders, Filipinos, and South Asians having diabetes prevalence close to 30%. The Centers for Disease Control predicts that by the year 2050, 1 out of 3 Americans will have type 2 diabetes. Among Native Hawaiians, Pacific Islanders, Filipinos, and South Asians, we're already there. And if you look at Southeast Asians, Japanese, Koreans, and Chinese, their diabetes prevalence also exceeds that of whites despite low BMIs, despite the absence of general obesity. So that's California. 1/3 of all Asian Americans reside in California. What does diabetes prevalence look like in other parts of the country? We used NIH data from 2011 to 2016, and if you look at the blue bars, the darker bars represent known or previously diagnosed diabetes, and the lighter shades represent undiagnosed diabetes or diagnosed at the time of the NIH visit. And you'll see that Hispanics, non-Hispanic blacks, and then number 3, Asians, have the first, second, and third highest prevalence. But when you disaggregated the Asian subgroups into East Asian, Chinese, Korean, and Japanese, and then you have the South Asians and Southeast Asians, who are predominantly Filipino in this group, their diabetes prevalence of South Asians and Southeast Asians exceeds that of Latinos and blacks. And if you adjust for not just age and sex, but BMI also, you'll see that Southeast Asians, in this case Filipinos, as well as South Asians, have higher diabetes prevalence than groups that are traditionally perceived to be at highest risk. So this is an opportunity to emphasize the importance of disaggregating Asian subgroups. Globally, the International Diabetes Foundation published these data for 2021, and the burden of diabetes is in the Western Pacific region that includes Asia as well as Oceania, with over 206 million cases. Of course, these are also some of the most populous countries, and followed by India and Southeast Asia with 90 million cases. Is this a new observation? Well, this was actually recognized 60 years ago. We look back at the literature in this paper in Hawaii based on 38,000 migrants to Hawaii. This was before the current obesity epidemic. You'll see that 7 per 1,000 Caucasians had type 2 diabetes, and the rate was twice that among Chinese in blue, and 3 times that among Koreans, Filipinos, and Japanese, and over 7-fold among Native Hawaiians. And 50 years later, the North Kohala study in the Big Island of Hawaii looked at it. This was a door-to-door sample, so it was generalizable to the population. You'll notice that the BMI of whites in beige, of Japanese in green, Filipinos in the orange bar, and mixed Asians were pretty similar. BMI of about between 25 and 26 at the definition of overweight, and the BMI of Native Hawaiians was beyond 30, so at clinical obesity. You would expect diabetes prevalence to be similar among whites, Japanese, and Filipinos, but following the trends from 50 years earlier, it was at least 4 times higher in Japanese, Filipinos, and other mixed Asians, as well as Native Hawaiians compared to whites. And so that's prevalence data. What are the implications when it comes to cardiovascular and all-cause mortality? In chart A, you'll see diabetes-related all-cause mortality was highest among Filipinos, second highest among Hispanics, and then was also high among the Asian subgroups that are Vietnamese or Asian Indian. Among males, all-cause mortality that was related to diabetes, again, was highest among Filipinos, followed by Asian Indians. And cardiovascular disease mortality in chart B, you'll see that, again, Filipinos and Asian Indians had the highest CVD mortality, but you notice among Vietnamese, Hispanics, and non-Hispanic blacks, It's similar despite just recent recognition of Vietnamese being at high risk for type 2 diabetes. And then among men, diabetes-related cardiovascular disease mortality was highest, again, among Filipinos and Asian Indians. The Kaiser paper that was published in 2013 prompted the American Diabetes Association to reach out to 4 groups that had longitudinal cohorts to evaluate the BMI screening cut points for diabetes, which was previously at a BMI of 25 kilograms per meter squared. So the only longitudinal studies, the first one started actually in 1979. That was a pilot study led by Dr. Will Fujimoto at the University of Washington in Seattle. And between 1983 and 1991, he enrolled 420 U.S.-born second-generation Japanese Americans, as well as third-generation Japanese Americans. He had these elegant studies comparing diabetes prevalence among Japanese Americans compared to those in Japan and those in Brazil, and found higher diabetes prevalence among the immigrant or U.S.-born populations. So 1979, this was 45 years ago, that the recognition of excess risk in this group of Asian Americans was first recognized. So they had their clinical baseline visit with follow-up after 5 and 10 years. I was a new clinical instructor, not yet assistant professor, when I had the privilege of running into the late Dr. Elizabeth Barrett Connor at a conference. And not knowing my ethnicity, she mentioned, we noticed that at the Veterans Administration Hospital, the majority of patients in the dialysis units are thin Filipino men. They have access to care, they're in the Navy, they have to exercise frequently, they maintain low BMIs. Is there something, were they just diagnosed late, or is there something different in the pathophysiology of type 2 diabetes in Asians? We'd like to start a cohort, and that's how I was able to join UC San Diego. So we enrolled 453 women first with a baseline visit, followed 5 years later and 10 years later, and a baseline visit of 107 Filipino men. And the third longitudinal cohort is the MASALA study led by my friend and colleague, Dr. Alka Kanea. MASALA stands for Mediators of Atherosclerosis in South Asians Living in America. Their cohort consists of South Asians in the San Francisco area, as well as in Chicago, and they recently got funded to expand to New York City to enroll a large population of Bangladeshi taxi drivers. We also, so to inform the American Diabetes Association guidelines, we also collected data from the North Kohala study that's led by Dr. Healani Chang from the University of Hawaii at Manoa. The criteria was, for this analysis, they had to be over the age of 45, no prior diagnosis of type 2 diabetes, with concomitant measures of BMI, glycosylated hemoglobin, fasting glucose levels, and a 2-hour oral glucose tolerance test. What we found was if screening was limited to participants with a BMI less than 25, 37% of Asian Americans would be missed. That includes a woman with a BMI of 16 who was newly diagnosed during our clinic visit. She was 5'4" and 96 pounds. So we were glad to be able to influence the screening guidelines so that Asian Americans with a BMI of 23 or greater and has any of these risk factors should be tested. We don't know about the implementation of this practice in clinical settings. And working with the Joslin Diabetes Center at Harvard, we started this Screen at 23 campaign. We predict that there are over 500,000 Asian Americans who are undiagnosed, moving the screening guidelines just 2 BMI units would help us identify at least 300,000 Asian Americans with diabetes. Another important observation is the importance of a 2-hour oral glucose tolerance test. Using the all three tests, we found that diabetes prevalence was 18%. If you limit screening just to glycosylated hemoglobin measures, you'll only capture 9%. If you rely on a fasting glucose measure, diabetes prevalence or hyperglycemia will only appear to be 5%. So if screening is limited to a convenient glycosylated hemoglobin measure or fasting glucose, almost half of Asian Americans with diabetes might remain undiagnosed. And this is particularly relevant to Japanese and Filipino communities. This is from the Masala study with comparisons to the MESA study, which has 800 Chinese Americans, mostly from Los Angeles. And the mechanisms include, for South Asians with the blue line, more insulin resistance and lower beta cell function. And although the glycosylated hemoglobin test is convenient and participants don't have to fast, we wanted to compare sensitivity and specificity and how many Asian Americans would be missed by relying on an A1C cut point of 6.5% compared to an oral glucose tolerance test. And it looks like it ranges from 12.6% to 4.2% in Japanese. However, when you administer an OGTT, the percentage of Japanese triples. The implications are limiting diabetes diagnosis to just A1C measures alone could miss diabetes diagnosis among 1/3 of Filipino Americans, half of Native Hawaiians, and 2/3 of Japanese Americans. We conducted fundal photographs and found that an A1C cut point of 5.8% might improve the sensitivity to diagnose diabetes versus the current guidelines of an A1C cut point of 6.5%. And this cut point was also useful in identifying participants with retinopathy. Other studies have also shown that, also in the Kaiser population, that members who did not have cardiovascular disease, whites and South Asian individuals and East Asian women and Black men had A1C thresholds for major adverse cardiovascular events that were as low as 6 to 6.2%, less than the treatment goals of 7%. So what's causing this difference? This paper was published 20 years ago, and it's an example of a European man with glasses and a South Asian man with a beard, both with very low BMIs, 22.3. And DEXA scans were used to estimate their percent body fat. And you'll see that the South Asian man has twice as much body fat as the European man, even though they both have very low BMIs. So there are, body composition, including excess fat in the visceral adipose tissue, fatty liver, intramuscular fat, and pericardial fat also seem to increase the risk for diabetes. So we were interested in quantifying visceral adiposity in our multi-ethnic cohort. We had 450 in each group, and we conducted CT scans just in about 200 in each group, women who did not have cardiovascular disease. So you'll see what's boldface is that the Filipino women were slightly younger. They had higher college attainment, and that's consistent with national data, were less likely to have ever smoked, don't drink alcohol, and their exercise frequency was similar to whites. So you would expect them to have optimal outcomes. We looked at anthropometric measures, and Black women had the largest BMI, the largest waist girth, the most truncal fat by DEXA, the most body fat by DEXA. But look at diabetes prevalence. It was highest among Filipinas, 1 out of 3, intermediate in Black women, and lowest in white women. Then we measured visceral adipose tissue, and it was significantly higher among Filipinas, whereas among Black women, the excess was in subcutaneous fat. Here's an image of those measures. So on your left, this was a 6-millimeter slice between the L4 and L5 vertebra. This belongs to a 62-year-old Black woman with a BMI of 25, so just overweight, 5'7", 160 pounds, and the red areas represent visceral adipose tissue. She had 25 cubic centimeters. Compare that to a Filipina with a BMI of 20, 5'4", 115 pounds, 26-inch waistline, and she had more than 3 times the volume of visceral adipose tissue compared to the Black woman. And this persisted at every level of waist girth. So this graph represents visceral adipose tissue just among women with a normal BMI, defined as a BMI less than 23 in Filipinas and less than 25 in Black and white women. You'll see in the yellow line that Black women at every waist circumference had the least visceral fat, but Filipinas in orange had the most. So this also raises issues about how we define who is overweight, who is metabolically healthier but at a higher BMI, and this observation of lower visceral adiposity among African descent participants has also been observed in the UK and in the Caribbean and Brazil. We also found that Filipinas had more pericardial fat compared to white and Black participants. And in the MESA study, you also see in chart D that Chinese Americans had more pericardial fat compared to African Americans and South Asians. Whites also had excess pericardial fat. And the excess subcutaneous fat that we observed in our cohort was also present among Black participants in the MESA study. This compares Masala data to MESA data, and you'll see that South Asians had more liver fat, more visceral fat, as well as Chinese Americans, and African Americans had the least. And South Asians also had less lean mass and more intermuscular fat, and the fat distribution exacerbates the risk for insulin resistance. In the normal weight category, you'll notice that in the red dots, up to almost half, 40% of South Asians were of normal BMI, but were metabolically abnormal. So what is it about visceral adiposity? It's not just a place where we store our excess calories. It's an active endocrine organ. We looked at IL-6 and TNF-alpha. We were also very interested in adiponectin, which is downregulated in the presence of excess visceral adipose tissue. And we compared adiponectin among just the normal glycemic participants. And Filipinas had half the adiponectin concentration compared to whites. Blacks had 40% less adiponectin compared to whites, even adjusting for anthropometric markers, insulin, as well as insulin resistance. And a study at the University of San Carlos in Cebu in the Philippines identified a polymorphism that seemed to explain the lower adiponectin levels. And prospectively, Dr. Fujimoto and his team were able to identify the longitudinal association between visceral adiposity and the risk of type 2 diabetes, even after 10 years, and that the change and increase in visceral adiposity is independently associated with a greater risk of developing type 2 diabetes after 10 years. So next I'd like to talk about in utero exposures. And this paper showed that maternal undernutrition is associated with the risk of visceral adiposity. We looked at, one thing that we wanted to look at in an opportunity in epidemiology are international studies. So our cohort in San Diego were predominantly immigrants. We compared BMI and fasting hyperglycemia as well as OGTT measures to third-generation Filipinos in Hawaii, as well as Filipinos in the Philippines from the same regions from where our participants migrated. And you'll see that mean BMI was lowest in the Philippines, intermediate in San Diego, and highest in Hawaii. You'll see that obesity prevalence was highest among third-generation Filipinos in Hawaii, but there was no difference in fasting hyperglycemia and no difference in diabetes by oral glucose tolerance tests, which leads us to believe that there might be a role in the relationship between colonization and type 2 diabetes. So Native Hawaiians and Pacific Islanders, especially in American Samoa, the Philippines as a U.S. colony, India as a UK colony, our exposure to a Western lifestyle and diet occurred back home. It didn't require migrating here, and perhaps that's why we're not seeing any difference in diabetes risk, a difference in body size, certainly. We also looked at duration of years in the United States. So studies among Puerto Ricans, for example, show that similar patterns where acculturation takes place in the home country. There was no difference in BMI if you've lived in the U.S. for a long time or if you are a recent immigrant. There was no difference in body fat percentage by DEXA, and there was no difference in truncal fat or type 2 diabetes. And gestational diabetes is known to exacerbate your risk for type 2 diabetes, usually about 22 years later. Kaiser data showed that among 200,000 births, Asian Indians had the highest prevalence of gestational diabetes. This was 20 years ago, followed by Filipinas, Southeast Asians, all the other Asian subgroups in blue, higher than Latinos, blacks, or whites, and preconceptional obesity is a known risk factor for GDM. Some mechanisms suggest that the risk for diabetes occurs during fetal development, results in poor beta cell function, differences in body fat and regional adiposity, resulting in impaired insulin secretion or impaired insulin action, and that is exacerbated by environmental and epigenetic factors as well. Recent data, and this was as recent as 2017, shows that currently in California, it's actually Vietnamese who have a high risk for gestational diabetes, especially Vietnamese who with a BMI less than 23. You see that highlighted in green. And even among women who had a preconceptional BMI greater than 23, Vietnamese women had the highest GDM prevalence, whereas Samoan women had the lowest, despite 60% of the Samoan parturients were clinically obese. Some polymorphisms have been identified with a higher risk for gestational diabetes in the Philippines. This is at the University of Santo Tomas. And then among Filipinos in Hawaii, some polymorphisms that are associated with type 2 diabetes were also shown to be associated with gestational diabetes among Filipinos in Hawaii. And so that prior gestational diabetes was associated with an increased risk of elevated glycosylated hemoglobin among Asians. There are also, so I'd mentioned about the risk of diabetes starting in infancy. This was a paper that was referring to South Asians and wanted to show some of our data when it comes to in utero and life course exposures. The Dutch Hunger Winter Family Study showed that women who were pregnant during the winters of 1944 and 1945, when the roads were blocked for the delivery of food during World War II, resulted in famine, women consuming as low as 500 calories a day. And what was shown was that when these babies turned 60 years old, infants who were in the first trimester of gestation during that winter had impaired insulin secretion and higher risk of cardiovascular disease. There was also similar evidence. The Chinese famine that occurred between 1959 to 1961 showed that those adults who are now in their early 60s also had a higher risk for type 2 diabetes as adults. Some of the mechanisms have shown that in murine models, a low-protein diet alters mRNA and mTOR expression in the offspring, which impairs insulin secretion and glucose homeostasis. So these are some important considerations among communities that are impoverished, that have less access to food, that are displaced, that are in war environments, or even by choice who follow a low-protein diet during gestation. So we didn't have access to caloric intake in our cohort, but the majority of our cohort were also born during World War II, during the Japanese occupation of the Philippines. And we measured sitting height as well as standing height, and leg length is a good proxy for a good estimate of childhood malnutrition. And what we found was, compared to our participants with the longest leg length, our participants with the shortest leg length had 3 times the risk of coronary heart disease compared to women with the longest leg length. We also found that our participants who were born before the Japanese occupation were about 2 centimeters taller than those who were conceived during the war or even afterwards. Other risk factors for diabetes in our cohort of Filipinos is multiparity, having more than 6 live births, and that's independent of visceral fat, independent of adiponectin, having low muscle to total abdominal area ratios, insufficient sleep. We are overrepresented in the healthcare professions, especially in nursing. 1/3 of our 450 participants were nurses. We didn't ask about shift work, but this might explain the insufficient sleep patterns. Of course, a family history of type 2 diabetes, hypertension, and last week's talk focused on social and structural determinants of health. Among our participants without a family history of type 2 diabetes, lower education, sustained childhood and adulthood social disadvantage were independently associated with a risk for diabetes, emphasizing the importance of interventions to make preventive information available to these communities. So this cycle of low plasma adiponectin concentration and visceral adiposity accumulation seems to persist and seems to independently predict accumulation of visceral adiposity. I think one value is what kind of utility might adiponectin have in terms of complementing current screening initiatives. I know synthetic adiponectin was very exciting several years ago, especially the benefits of lowering triglycerides. It's very challenging to synthesize, but what value might adiponectin have in terms of augmenting screening? Here's some data from the parity data. You'll notice that as women had more live births, the BMI increased slightly, but more importantly, visceral fat increased once you had at least 3 live births or more. And type 2 diabetes occurred in half of parturients of women with 6 or more children. So having multiparity was associated with a higher risk of diabetes independent of visceral fat and adiponectin. Britta Larson from UC San Diego also wanted to look at regional fat distribution, and among postmenopausal women with diabetes, they had less abdominal muscle and significantly more visceral adipose tissue. What are the implications for interventions? Perhaps increasing muscle mass might be an effective intervention instead of losing weight, especially how do you convince a woman with a BMI of 20 and a 26-inch waistline that she needs to lose weight? So increasing muscle mass might be an effective intervention by improving insulin sensitivity and preventing or delaying insulin resistance. There's actually a study that was ongoing at Stanford. Their sample sizes may have been underpowered. They had 40 in each group. One group was randomized to strength training, another one to aerobic exercise, and a third a combination of both. But that might be an intervention that low BMI participants would be receptive to. Here's some of our sleep data by Aladdin Shadyab, who was a PhD student at the time, now faculty. And you'll see the sleep deficiency among Filipinas with almost 60% sleeping less than 7 hours, and a fourth sleeping less than 6 hours. And then with regards to hypertension, since 1984, Filipinos and African Americans have sustained the highest risk for high blood pressure in California. And these, again, are Kaiser data. You'll see blacks in blue and Filipinos in that olive color, and they're very close to each other among women across all age categories, and among men, the hypertension prevalence for black and Filipino men are identical. So how can we improve hypertension control as a means of preventing diabetes? In 2021, we had the opportunity to gather all of the diabetes and metabolic abnormality researchers. So this was led by Dr. Kanea from the PI of the Masala study to identify gaps, challenges, and opportunities in health and prevention for Asian Americans. We were so delighted to share our work with NIH and specifically NHLBI. And we're thrilled when this announcement came out for a cohort, a new epidemiologic cohort among Asian Americans, Native Hawaiians, and Pacific Islanders. And this was issued 2 years ago, and enrollment is already, the sites have been selected, the coordinating centers, the clinic centers, and we look forward to a national study that could help us further elucidate the etiology and pathophysiology and the opportunities for treatment and management among Asian Americans with diabetes. So this is the new NHLBI study that focuses on AA and HPI communities. And learned just a few days ago that a director for Native Hawaiian and Pacific Islander health is being recruited by NIMHD. And these studies were collectively funded by different institutes of NIH, the American Heart Association, and the Department of Veteran Affairs. Thank you.
Okay. So anyone has any questions, please.
Hi, Dr. Araneta. I really enjoyed the talk. It's quite enlightening. I have a family history of diabetes, so I monitor my hemoglobin A1C, and obviously maybe that's not enough. I need to try some of the OGGT. So the question I have for you is that in light of a lot of the difference you have shown with the Asian population, how different from the white and black population in terms of diagnosis, have you looked at the area of early treatment of prediabetes and diabetes? Because there's been a lot of discussion about whether we should be more proactive in treating people with early or prediabetes. I wonder whether there's some area that would be relevant, especially for Asian American who have high likelihood of diabetes, whether they should be more progressive or more proactive in terms of treating them and monitor them?
Sure. So the Diabetes Prevention Program, the DPP study, which was started over 20 years ago, randomized pre-diabetic adults to either a lifestyle intervention, and that included exercising 150 minutes a week plus losing 7% of your weight, or metformin or placebo. And what they found was there was a huge benefit to lifestyle interventions, including among low BMI participants and Asian participants. Metformin seemed to be less effective in a similar DPP study in Dashing as well as in India. So I think the first intervention that participants might be receptive to, because it was more efficacious, is a lifestyle intervention. And again, I think the public health message has always been lose weight, exercise, but maybe it's the type of exercise. And once the numbers for the strength training data are increased, it might be worthwhile to consider that, but also to promote that in communities. Many of our participants with 26-inch waistlines will tell you, I don't need to lose weight. And on TV, what I hear is that it's only the overweight people. Or they'll walk, but they haven't heard about the benefits of strength training to improve insulin signaling.
Well, also diet, right?
And diet. So diet was interesting because the questions we often get is, it must be the rice. And among our 453 participants, we tried to look at differences between participants who ate 1 to 2 cups of rice a day versus less than half a cup. We had 0 people in our comparison group because they all ate rice. But I think, so what we did find, though, among diabetics versus non-diabetics in Filipinos, what was associated are lower caffeine and lower dairy intake was associated with a higher risk for diabetes. So lattes are good for you. But what we also found, too, was that we had a student, Sheila Medina, who was looking at adiponectin concentration. So monounsaturated, polyunsaturated, omega-3, and omega-6 levels were inversely associated with adiponectin. That was just cross-sectional. We didn't have a chance to look at it prospectively, but that might explain some of the opportunities for dietary interventions.
Hi, Rafael from NIH LBI. First of all, thank you so much for a wonderful talk. I think it was really enlightening. I wasn't that aware that the Pacific Islanders, Native Hawaiians, and Asians in general were at higher risk of developing diabetes. Now, the question here that I want to ask you, it's a two-part. The first part, we know that ApoB containing lipoproteins also augment or increase the risk of developing type 2 diabetes in overall population. But has this been studied in Asian Americans?
Not in our cohort. I think it might have been evaluated in the Masala study.
Okay, yeah. And now, have you found any lipid abnormalities, differences between other ethnicities and Asian Americans?
We found that in our cohort, for example, African Americans had the best lipid profile. Filipinos had high triglycerides, very low HDL levels, despite reported high exercise frequency.
Yeah, because we know that also the VLDL secretion is altered in type 2 diabetes, but is this has this been studied specifically by ethnicity or?
Yeah, we didn't measure VLDL, just LDL cholesterol.
Okay, well, thank you. Thank you so much.
But it might be an opportunity for the new cohort, the new national cohort.
Yeah. In the sense, perhaps either calculating LDL with the new Samsung formula or calculating also small dense LDL would like aid to see if there's a difference in the lipid burden and cardiovascular disease, especially in this population?
Yeah, we can certainly look at that. With regards to cardiovascular disease, we administered the Rose questionnaire. We also looked at coronary artery calcium at visit at 5 years and at 10 years, and found just more subclinical atherosclerotic disease among Filipinas.
Okay,
And-
that's really interesting.
Yeah.
Thank you so
And then
much.
a higher risk for progression 10 years later.
Exactly, yeah. Yeah, overall higher cardiovascular risk. Right. Yeah, thank you.
Thank you for that wonderful talk.
Thank you.
So from looking at the data and the review of the literature, it basically means South Asians have higher visceral adiposity, lesser subcutaneous fat depot, they are more insulin resistant, and they have relatively poor beta cell dysfunction in the setting of caloric excess, obviously. So all of these factors are very similar across different ethnicities, and genetic studies really don't show any specific, variant. If you look at large databases, there's really no additional genetic predispositions for Asians to develop to explain the higher risk. So given what we know, what can we do now, right? The cross-sectional studies don't show causality, and we are not identifying any new novel factors. I mean, we can keep looking for it, sleep, et cetera, et cetera. But the prevalence of diabetes is exploding, so what do we do about it now? And what should the NIH really focus on? My own thesis is it's just excess adiposity. If you actually look at fat percentage, if you do a DEX on all of them, which we can't obviously do, and instead of looking at BMI, we have known, like South Asians who look like me, are actually at more fat, because if you look at the fat amount of fat that I have. So what do we do about it now? What are some of the interventions that we can actually do with the current drugs that we have to prevent the rise that we see?
Right. I think the first step is optimal screening. So the NHANES data showed that 40% of the Southeast Asians, Filipinos, and East Asians were undiagnosed. And I think with earlier screening, earlier detection, that allows you more opportunities to prevent micro and macrovascular diseases. I think there's still a lot to be learned about why South Asians accumulate hepatic fat, but Japanese, Filipinos, and Koreans accumulate visceral adipose tissue. I think there's still a lot of knowledge to be gained by understanding the mechanisms for the different fat compartmentalization and practical lifestyle interventions, diet or exercise, that could prevent that accumulation. I think opportunities, as I mentioned, maybe to use adiponectin to augment current screening. There, I met with some staff from NIDDK who were also interested in looking at Ozempic, for example, even among lean individuals, to see if there's a benefit towards reducing insulin resistance. So I don't know what could be recommended from medical management, but I think raising awareness about who's at risk, to expand the public health messages that it's not just people who are overweight or obese that are at higher risk. I think what can the NIH do? I think creating this new inaugural cohort, a national study of Asian Americans, is a big step, whereas previously with Dr. Fujimoto, Dr. Kanea, and my cohort, they were funded by small RO3 grants and using different protocols and different laboratories. So I think a way to systematically address these mechanisms in a large cohort using the same protocol is a huge step for NIH.
Thank you.
Thank you.
Okay, we do have a few questions online, if you're
Yes, please.
still holding up.
Okay.
Don't know if you answered this during the Dutch hunger conversation. Does gestational diabetes in Asian Americans raise the risk for diabetes for their children?
I don't know, because it's relatively, so gestational diabetes was initially recognized in 1973, the early 1970s. so that if there was a GDM mom who was born there and she would just be around 50 now, and if she has a child who is 25, would that child be at risk of GDM? I think it's still early to tell, but my guess is probably yes.
Okay. Let's see. Thank you for this comprehensive talk. It was very eye-opening for me, particularly the low BMI aspect. Does your data include Pacific Islanders still living in their native islands in U.S. territories such as Guam or Northern Mariana Islands? My understanding is that both their obesity and diabetes rates are high, and this is blamed on the adoption of U.S. or non-traditional foods. Do they have improved health outcomes when moving to the mainland?
So our data did not include Polynesians, Native Hawaiians, or Pacific Islanders who remain in the Oceania area. Our Native Hawaiians came from the North Kohala study, so residents of Hawaii. I think there is, with regards to body size, there is a big difference in obesity prevalence in American Samoa versus Western Samoa. And I'd mentioned the role of colonization and the introduction of Western diets and lifestyle, and there's if that explains the difference in obesity risks among the two. Do their conditions improve once they come here? I'm not familiar with that data, but I think the establishment at NIMHD for a new, they had a workshop on Native Hawaiian Pacific Islander health in February, and now are recruiting for a director gives opportunities to study these populations which are sometimes dismissed as too small, and just emphasize the importance to serving a population that's a significant part of American history.
Okay, and maybe one more. Is language a unique challenge to Asian Americans in accessing healthcare and diabetes management resources?
Absolutely. I was born in the Philippines. We have 187 dialects. And so when we were recruiting, for example, we just so happened between our nurse clinical coordinator, our phlebotomist, our driver, and myself, we were able to cover 6 of those 187 languages. The language deficiency became very pronounced during the COVID-19 pandemic, where San Diego, 35% Latino, there were only Spanish-speaking interpreters at the COVID vaccination mobile shops. They had to rely on our Vietnamese and Tagalog-speaking students to provide translation services. So unlike Spanish-speaking communities, generally that's one language that most people from Latin America will understand, but among the Asian American migrants, that's in excess of over 40 languages. India alone has 125 languages. But there's also this misconception that colonized countries, the Philippines, India, Malaysia, are English-speaking. We speak functional English, but that doesn't translate into, will a patient understand instructions, guidance from their physician or nutritionist if they speak functional English versus if guidance is provided to them in language that they comprehend. So very important consideration. We talk about cultural concordance, having physicians and patients who come from the same racial and ethnic background translates into prove outcomes. I think it's even more important to have language concordance.
Okay.
Thank you.
So let me repeat the CME code 50126. For everyone here, there's a reception outside with no doubt very healthy food. And let's thank our speaker.
Thank you very much.